Hello, thanks for joining me today. I'm Betsy Nicoletti. This is the fourth in our series in which and today's topic is preventive medicine and Medicare wellness visits. Wellness visits, everyone's favorite. And we're going to pay particular attention to when we can bill a problem-oriented visit on the same day as either a preventive medicine service or wellness visit. I am a big science fiction fan. And in one of the Star Trek movies, our heroes are in a shuttlecraft and they're going to get the new Enterprise. They've blown up the Enterprise. They blow up the Enterprise in every single movie, and somehow Starfleet keeps giving them more Enterprises. But Dr. McCoy says, in relation to what they're going to get, the bureaucratic mindset is the only constant in the universe. And I often wonder what Dr. McCoy had to complain about. He didn't have RVUs. He didn't have to worry about diagnosis coding. I never even saw him write a note. But I do think about his statement about the bureaucratic mindset and complexity when I talk about preventive medicine and wellness visits, things that should be fairly simple, but in fact are complex to code. So we're going to talk about the CPT preventive medicine codes, what CPT says about adding a problem-oriented visit. I am going to talk about the Medicare wellness visits, although I know they are no one's favorite, and adding a problem-oriented visit when we do that. And then we'll pay a little bit of attention to some of the pay for performance reporting that we do for payers. So when I think about what's the difference between a preventive medicine service and a problem-oriented visit, I sometimes think about whose list are we looking at? So the patient comes in for a problem-oriented visit, they've got complaints, they need refills. I shouldn't say patients have complaints. We have issues we want to talk about with our clinicians. And sometimes everyone's also favorite. I found these 20 pages of information on the web, and I know you haven't seen this information, but can we talk about that? So I think about the problem-oriented visit as the patient's list. But then for a preventive service, I think about that more as your list. You want to talk about how they're due or overdue for a mammogram or colorectal screening. You want them to get a flu shot or a Pneumovax if they're eligible for that. You want to screen them for depression and substance use and other health issues, other behavioral issues that might affect their health. And you want to give them advice related to car seats or sunscreen, depending on the age of the patient and their physical health. You want to give them some anticipatory guidance. Now, I know that practically speaking, it isn't that there's a distinction in the exam room that is as clear as these two lists, and that things often, while you're performing one service, you're also doing the other services as well. But from a coding perspective, a problem-oriented visit is a medically appropriate history and exam. We know that the requirements for history and exam in determining our level of service were dropped in 2021. So if we're doing an office visit, we're assessing it, we're selecting the level of service only on the medical decision-making, but the note will still include a medically appropriate history and exam when performed, an assessment of an acute or chronic problem, and a treatment plan. Whereas when we're looking at a preventive service, it's an age and gender appropriate physical. You provide or order screening tests, immunizations are a part of it, and it's that anticipatory guidance and advice that you give to the patient. But in the exam room, it isn't that there's that much of a distinction always between the two types of service. So you could be seeing a patient for a chronic condition, and you notice that they haven't had a screening for a cervical cancer, and you say, we really ought to do your pap smear, or we need to schedule that. And we'll give you your flu shot today. Or you're doing a preventive service, and at the same time, the patient brings up a problem-oriented, brings up an acute problem, or you discuss their chronic problems. So I'm going to talk about what your options are for reporting services when they're partly one of each. So included in the preventive medicine, an age and gender appropriate history and exam, risk factor reduction and anticipatory guidance, referral or provision of screening tests, immunizations, and these codes are 99381 to 99397. And immunizations we'll come back to. You know, you can bill for the administration of those separately. Original Medicare considers these 99381 to 99397 codes routine and still doesn't pay for them. Some Medicare Advantage plans do pay for the CPT preventive medicine codes. And the problem with that is someone needs to check on that. That's not something that you as a clinician can know, oh, this Medicare Advantage plan does or doesn't. They're defined by whether the patient by the age of the patient and whether the patient is new or established. And a new patient is a patient who's never been seen by you or your same specialty partner in the past 3 years. The same definition as whether it's a new or established patient for a problem-oriented office visit. For CPT, the extent of the focus is largely dependent, the service is largely dependent on the patient's age. They tell us that the comprehensive history and exam are not the same as the comprehensive history and exam as we had in the old documentation guidelines. And it does include this counseling, anticipatory guidance, and risk factor reduction. If you buy the immunizations, if those are an expense to your health center, then we bill for those. If you get those for free, we bill for the administration of those. And then ordering of the screening tests that the patient needs and should have based on their risk factors, age, and other issues. So the CPT Assistant, there are a couple of quotes from the CPT Assistant in the presentation. And when you see how old they are, this one's from 2009, there's one from 2002, you can see how little has changed in billing for preventive medicine services from a CPT perspective. So they just give some examples about the differences in the physical exam and the anticipatory guidance and counseling for one age person and another age person there. And that makes sense. And in fact, when these codes were amended last, the CPT Assistant, which is published by the American Medical Association and is our source for coding, not for reimbursement issues, but for coding, they said, if you have questions about what is included in these, talk to your professional society, the AAFP or ACP or the American Academy of Pediatrics or ACOG. Now you're going to bill for additional services, lab tests that are done in the office, the administration of the vaccines, venipunctures, hearing and eye tests. And here's a time. Typically the hearing test, the CPT book tells us when you've done the service, you report the code that is related to it. I don't know any practice in the country that's getting paid for the separate eye test at a well child visit. And of course, you are an FQHC and have a PPS rate, but it's still important to write down what you've done. And the way we do that is when you check out, when you close the note and you're checking out that patient encounter, that you document and report the services that you've done. So this is a question I get asked all the time, how to bill for a pap smear. And of course, it varies. So when a pap smear is done at a preventive medicine visit, then it's part of that age and gender appropriate physical exam. And we don't charge differently for it. It doesn't change the coding. So if it's a patient who needs a pap smear and because of age and frequency, how frequently, when the most recent pap smear was done, we don't get paid more for doing the pelvic and the pap. Or if it's a patient who's over age or has had a pap smear recently and doesn't need to have it done again, you don't get paid less for it. And I'm going to mention this again, although we think of Medicare as a service that a patient gets at 65, patients who are younger and are on disability for 2 years may be on Medicare. So you may have a younger patient who's on Medicare, and patient who is older. So if we think about the patient who's 65 or 70, some patients have Medicare as their secondary payer because their spouse is still working. So what about, this is a problem that comes up in all primary care and GYN practices. The patient comes in for their annual exam, but they're having their period, and so they can't have you're not going to do the pap smear today. And now they return 2 weeks later for the pap smear. What are we going to bill for it? So we know we can't bill the 99395 or the 99394 or 6 again. We can't bill the preventive medicine service a second time. So what do we bill when the patient comes back? So ACOG recommends that you bill an office visit, a low-level E&M service for it. There isn't a CPT code for a second partial visit. The other problem we have with getting that paid is a diagnosis code. So sometimes the payer won't pay it because they don't pay a second preventive CPT code, and sometimes they don't pay it because we don't have a diagnosis code that supports it. If the patient does come back for the pap smear only, and it's part of their preventive service, not a diagnostic pap based on having an abnormal finding before or need for more frequent pap smear, but for a screening, then use ZO 1.411, ZO 1.419, and examination codes with or without abnormal findings. And by the way, those codes, with and without abnormal findings, you don't have to wait to get any lab work done. It's at the time of the visit whether you find abnormal findings. Now, Medicare has a HCPCS code. Remember HCPCS codes, these start with a letter and have 4 numbers. Medicare develops them, generally not recognized by other payers. I've got that coming on a later slide. So in addition to billing for the exam, it's helpful if you can add the screening cancer codes, because your health center can receive additional resources in future years if you are doing cancer screenings at the recommended rates. And for some of them, so let's talk about the screening for cervical cancer. The pap smear is going to get billed, so the payer is going to know that you did the screening. But if it doesn't take until 8 o'clock at night for you to find these specific screening codes, it's helpful if you also add them to the claim form, which means put them in when you check out. It'd be great if there was some kind of a workflow that if you're ordering a pap smear, you would have a list of codes that you could choose from, including screening for malignant neoplasm of the cervix. If you do a breast exam, we can add the screening for malignant neoplasm of the breast. And if you order a colonoscopy or give the patient some occult blood cards, then screening for malignant neoplasm of the colon as well. And here's that code that I mentioned, the Medicare code. I'm not recommending that you start using it or that you look it up or find it. I just wanted to let you know that there is this code. Medicare, it's an old code. Because Medicare didn't recognize preventive medicine CPT codes, long before we had the wellness visits, we had this code for screening for cervical and breast cancer. So I'm just put it in for informational purposes only today. So how do you bill for a pap smear at a problem-oriented visit? Again, the pelvic and the pap are part of the pelvic exam is part of the exam for the problem-oriented visit and obtaining the pap. And the pathologist bills, of course, for the interpretation. So if you have a patient who needs, again, more frequent paps because they've had an abnormal pap smear before, you are billing a problem-oriented visit without an additional code for the pap smear. All right, what about treating problems? And this is, oh, great. So Lynn, thank you for chiming in that your clinicians are really good at capturing those. That's very helpful to know. Sometimes, speaking to the choir. So what about treating problems? So what if you're doing a preventive medicine service and the patient either has an acute problem or they have chronic problems that you're addressing at the time of the visit? CPT and Medicare, when we get to wellness and Medicare, say that you can bill for a problem-oriented visit on the same day as a preventive medicine service. And when would you do that? When the history documented some symptoms that the patient had or the status of their chronic diseases, and the assessment in the plan documented the condition, status, plan for the acute or chronic condition. There isn't an additional payment for in your PPS rate, but you're counting the visits. So if you've done 2 services at the visit, you can bill for both. And Medicare Advantage may pay for both. So before I go to the CPT definitions, the citation, let me just talk philosophically about this, because this is a problem in every primary care practice in the country, in every family doctor, pediatrician, internist, FQHC, rural health center. So the patient is scheduled for their preventive service. And at the time of the visit, you also treat an acute or chronic problem, or the patient brings up an acute or chronic problem. What are you going to do? You can provide 2 services, but only take credit, but only count 1 service. That's never my recommendation. You can, if the patient has a lot of problems, they brought you in a list as big as my handout, you can say, look, we can deal with 1 of those today, but you have to reschedule to come back for the rest. Or let's do a problem-oriented visit today, and we're going to reschedule your preventive service. I mean, if the patient's really sick, you can do that. Or you can perform both and bill for both. So yesterday when we did this, one of the physicians said that when a patient has chronic conditions at the time of the preventive service, that he typically will give the patients, he doesn't bill for both, he'll give them a 30-day refill and schedule for them to come back. So that seems like a reasonable thing. There is a tremendous variation amongst clinicians about how they do this in every practice and across the country. But I am an advocate that in primary care, that we shouldn't be editing ourselves. We shouldn't be saying, oh, we don't want to bill too high. We don't want the patient to complain. If I go into the orthopedic surgeon and I have shoulder pain, the orthopedist is going to bill me the E&M service. And then if she injects both shoulders, she's going to bill for both injections. She's not going to say, oh, Betsy is so nice, I'm not going to bill her for both, I'll just bill her for 1. Or I don't want Betsy to complain. So that's my ad for if you've done it and you've documented it, let's report it. Let's take credit for it. All right, here's what CPT says. If an abnormality is encountered or a pre-existing problem is addressed when you're doing the preventive medicine service, and there's significant additional work for the key components, they didn't edit that this year, for the key components of the problem-oriented visit, then bill an office visit with it. And your billing team will add modifier 25 to it. And then they say, if it was an insignificant or trivial problem, don't add an office visit to it. Seems straightforward, except one of your ideas of what's insignificant or trivial and another may vary, of course. So in 2002, they gave us some examples. The first one was an abnormal finding on physical exam. So in this case, there wouldn't have been anything up in the HPI about the patient, in all likelihood, about the patient complaint. But during the exam, there was an abnormal finding. CPT says you would bill for the office visit, and you would bill for the preventive medicine service, and we're going to choose a exam diagnosis code for that, and you're going to bill for the office visit, and we're going to choose the breast lump or the condition for that. So you're going to need a different diagnosis to support that. And the other example that they gave was for a reevaluation of hypertension, diabetes, and chronic stable angina. And they say there was an additional specific history. They talk about an additional exam of vital signs, heart, and edema. I think that would be part of most physical exams. I've never understood how the physical exam was different for that, but they note that themselves. And they talk about medication compliance. And so it's treated at the time of the visit. And they say you would, for those existing problems, bill for both. Again, how you opt to do that in your practice, whether you say, we don't have time today, there's a lot to cover, you've got to reschedule, or whether you say, yes, I'm going to, I mean, obviously, if it's urgent, you're going to treat it, but yes, we're going to deal with all of your problems. So that's clinician determined. So 99381 to 99397, these CPT codes are still considered routine by Medicare. Some Medicare Advantage plans pay for these. So as your Medicare Advantage population grows, you can get paid for these services, which I know are the visits that you like, not the visits that we have to use for traditional Medicare, the Welcome to Medicare, and the initial and subsequent annual wellness visits. And I do know that these codes are not universally loved. I don't just hear complaints about them in FQHCs. I hear complaints everywhere we're treating Medicare patients. I think of them, though, as an opportunity for you to have a block of time to talk to your patient about the same things that you would have when they were 64 if they got Medicare at 65. Anticipatory guidance, risk factor reduction, what screening tests they need, are due for or overdue for, and that they need to have. And some of them are really once in a lifetime opportunities. So there are 3 of them. Welcome to Medicare, also known as the IPPE, which I love it. It stands for Initial Preventive Physical Exam, even though an exam isn't required. The annual wellness visit, initial, and the subsequent wellness visits. So the Welcome to Medicare and the initial annual wellness visits are once in a lifetime opportunities. The patient is eligible for it in the first year they're enrolled in Medicare, which may or not be, as I mentioned, when they turn 65. If they are transferring into your practice, for example, and they received that Welcome to Medicare visit in their prior practice, they're not eligible for it anymore because it isn't a Welcome to Medicare visit in the first year for each clinician that they might see or for each practice. It goes with the patient. And the initial annual wellness they're eligible for that after a full 11 months have passed from the Welcome to Medicare, or if they never received the Welcome to Medicare visit. So they're 67, they never had the Welcome to Medicare visit, they get the initial annual wellness visit. And then the subsequent annual wellness visit, eligible after 11 full months have passed. Now you say, how will I know which one? And of course, you can't know as the clinician. Patient eligibility can be checked on the Medicare website, and some groups do that. Before the patient comes in, they go online and they find out which of those visits the patient is eligible for. The other difficulty about this is reporting the visit depends on selecting the correct visit type when the appointment's made, and the correct template when the patient is roomed. So if it's set up as a regular CPT preventive service, you're not going to have all those screenings done when you come in to see the patient. The medical assistant won't have asked all those questions. So there's no way you can complete the requirements of that. So we've got to have the correct visit type, and the template has to be pulled up and is correct and be correct. One thing that some groups do is if they're seeing a patient for a problem visit, a regular checkup, at that visit, they've, renewed the patient's prescriptions, addressed things. That's a time when they can schedule the patient. Go out and schedule your Medicare wellness visit. I also recommend using one template for all 3 visits and including all of the components for both. And the reason is then it can be done behind the scenes. So you took the change if we selected the wrong one. So you chose the Welcome to Medicare visit, but it should have been the initial annual wellness. If everything is included in the template for both sets of visits, for all 3 of those visits, then it can be switched behind the scenes. We don't have to say, oh, we were missing something that we needed. And here's really the difference. The wording is different in the visits, and it's described in the preventive medicine handout, what Medicare requires. But the difference is Welcome to Medicare requires the test for visual acuity. So you got to do the Snellen, but just do it on everybody, Medicare age. And the annual wellness visit requires an assessment of cognitive function and a list of current medical providers. Now, what I sometimes find is that we have put too many questions into our template. So when these visits came out, the AAFP and ACP put out some templates. We were grateful because that meant we didn't have to make them. But they were about 6 pages long, both sides. I don't know, they were too long and they were duplicative. So you want to make sure that you look at your template and take out any duplication and take out information not required by CMS. Edit the screening questions to only what's required by CMS, and then think of a workflow that allows the medical assistant to update that information for the subsequent visits rather than starting them fresh every single time, because it's a lot of questions. And the subsequent wellness visit says update. That can help. The other thing is don't require more than CMS does. So if you go back and look at the CMS documents, the ABCs of wellness visits, it says a cognitive assessment is required. And that can be done through your observation. You're talking to the patient, you can observe if they have cognitive deficits or not, discussion with others, or review of old records. There's no requirement for a mini mental status test. There's no requirement for the clock being drawn. So if it's important to you and you feel like clinically that's relevant, then absolutely you want to keep it in. But what's required is cognitive assessment, your assessment of the patient's cognitive function. It's not prescriptive how it's done. So I always like to make a plea for making the content in the wellness visits the bare minimum, not because I believe in the bare minimum, but because it's going to make it easier for you to do. And what I find is if we've worked on our template and we are updating our subsequent wellness visits, the medical assistant is not in there with the patient for 40 minutes, and neither are you. We can decrease the amount of time these visits take. And I do know that you have a third party who's doing some of these visits, so it's not on you completely. Medicare says the same thing here in the ABCs of the initial preventive service and in wellness visits, that if you furnish a significant, separately identifiable, medically necessary E&M service, report it and put modifier 25 on it. And then they go back to the old, 1960 terminology from the original law that passed, and they say, that portion of the visit must be medically necessary to the beneficiary's illness or injury or to improve the functioning of a malformed body member. I think they could drop that language. So as your Medicare population grows and you perform these visits, you may also be treating the patient's medical problems at the same encounter. And if you do, you want to take credit for that by reporting it. I would expect to see something in the history of the present illness related to either the acute or chronic problems. And then in the assessment, remember, we don't have to write a book. We don't need 100 years of solitude. We're going to say diabetes, hemoglobin A1C, good today, continue current meds, whatever it is. Of course, sometimes it's going to be longer because you need to make it longer, but it doesn't, there's no requirement for the length of it. And that is one of the things that I like about the 2021 guidelines. I'm going off topic just a little bit. They removed some of the history and exam requirements the clinicians said weren't relevant. And they said, put in the note what is clinically relevant in the assessment and the plan. If you are doing these wellness visits as opposed to a third party doing them, this is your opportunity to report chronic conditions. That's what's recommended by the AAFP, and you want to make sure that you're doing that. All right, barriers. No one likes the visit. It's the opportunity to talk with patients about screening and immunizations. There's no exam. An exam's not required, but you're allowed to do the exam. Sometimes clinicians say to me, I'm not even allowed to touch the person at the visit. You are allowed to. The requirements, if I go and look at what CMS says it requires height, weight, BMI calculation, and other measurements as deemed appropriate. So you're permitted to do an exam. It's just that it's not required. And patients don't like it, oh, I went in for my physical, because they still think it's a physical when they go from 64 to 65, if that's when they get Medicare. And he didn't even touch me. So you're allowed to do the physical. Too many questions, review the template. The visit isn't scheduled as a wellness visit. There's no recovery from that. I don't think. Maybe in your system, it's easier to change the template around, but what primary care clinicians tell me is they get in there, it's not opened up as a wellness visit. They can't switch the template very easily. So we just want to work on that as a workflow issue. And I do believe if you're going to start doing them, you see the patient for a problem-oriented visit, ask that the follow-up be a wellness visit. Now, I know that this is pie in the sky because many of you have schedules that are so packed, you can't add that other visit in. I don't have a solution for that. And you don't know what visit to select. We're going to use a single template that includes all of the requirements for the 3 wellness visits. Now, I've put together 2 quick reference sheets. When are we going to bill just for the preventive service? And when are we going to add a level 3 or a 4? And why didn't I include a level 2? A level 2 visit is, a self-limited or minor problem, minimal or no data, minimal risk. So I don't think it rises to the level of the significant extra work that CPT tells us we need. So I would start as a 3. So we're going to bill the preventive only when the patient's in good health, they don't have chronic problems, or they have chronic illnesses, but you didn't manage them in the assessment. You didn't address those today. When they brought up something about their osteoarthritis, you said, we're going to ask you to come back and we're going to assess that in a more, when we have more time and we can do it more fully. A patient who's well, a patient who wouldn't have come to see you based on their symptoms, except that they had this annual exam scheduled. And when would you add a 99213 for a patient with an acute uncomplicated illness at the time of the visit, or a patient with one significant stable problem with the prescription renewed? And that's based on the MDM guidelines from this year. And when would you bill a level 4? A patient with, so let me go back. Patient who's got allergic rhinitis and they're on Claritin, even if you've got to send that over-the-counter drug in electronically, maybe you wouldn't bill anything for that. Patient with chronic rash, for example, and you assess it and it's not in good control and you send in a prescription for them, maybe we'll bill that as a 3. The patient with 2 or more significant stable problems. And now I'm going back to those conditions that CMS listed in their risk guide, conditions that are not expected to resolve. And they gave, congestive heart failure, COPD, diabetes, I think hypertension was on that list, chronic kidney disease, those type of Parkinson's, MS, those type of significant chronic problems. 2 of them that are stable with prescription drug management, audits as a 4. 1 exacerbation with prescription drug management, audits as a 4. Or a patient who presents with an undiagnosed new problem with an uncertain outcome. One of the first, I can remember how many years ago it was, one of the first preventive services that I read where I said, wow, this needed another visit, was a patient who had a 2-week history of bright red blood per rectum. I think I would have come in sooner. All right, so preventive services, I know that when you get up in the morning and you look at your patient list, your immediate response is not, boy, let's see how much revenue we can generate today. But I also know that it's important for you that your health center is thriving and is healthy, and that when your health center has resources, you can care for more patients and you can provide additional services for those patients. So you have some contracts that provide additional revenue to your health center when you do some of these preventive services. And how does the payer know you've done them? Either you're billing for them because you've billed for the hemoglobin, the test for blood in your stool, or by diagnosis code because you're using the screening diagnosis codes. Medicare does pay your health center 134% of the PPS rate for wellness visits, so it's a direct help to the health center. And then you want to think about workflow. Can you set it up so that when the medical assistant does the PHQ-9, that one of those HCPCS codes for depression screening gets added? Depression patient was screened with and was negative, patient was screened and has a positive result. So can we do that so that we take the burden away from you as the clinician and it happens behind the scenes? So there are these pay for performance metrics in your contracts, and we want to ask, how can we set these up so that when you do the screening for substance use or you do the screening for depression, that it goes into the system without you having to remember to drop the code? I'm going to just take a minute now and talk about the coding difference between screening and diagnostic tests. So ICD-10 says that screening is the testing for disease or disease precursors in seemingly well individuals. So what's covered? I would go to the U.S. Preventive Services Task Force website and see what conditions have an A or a B rating. You know what those are, of course. But I have to go look them up. And those are by age and gender, and then they have frequency. Some of them have family history in them. So those screening tests where you're doing the test, you're ordering the test for this patient who doesn't have a disease, doesn't have a sign or a symptom, we're going to start those and use a diagnosis code that begins with a Z. And there are some specific ones which can sometimes be hard for you to find. If we can get those into a file for you, that's always helpful too. We use a diagnostic, from a coding perspective, a diagnostic test, even though it's the same test, is for a patient who already has been diagnosed with a condition or who has a sign or symptom. So that's monitoring a known disease. So if you have a patient with no history of hyperlipidemia or hypercholesterolemia, no history of that, and they're of the age that you can screen them for high lipids, then we would use a diagnosis that starts with a Z. A patient who has already been diagnosed with lipid disorder, we would use hyperlipidemia as the diagnosis because now we're monitoring a known disease. The other one I get asked about that I'll just mention off the cuff is, can we get paid for hemoglobin A1C for screening? And the answer to that is no, that's not considered a screening test, but there are 3 glucose tests that for a patient with certain risk factors or prediabetes can be used, can be provided for a patient, and we would use the screening diagnosis. But then once the patient, if the patient is diagnosed with diabetes, we use a diabetes diagnosis. So I'm going to circle around here. So this is our 4th session. Next week, we're going to talk about coding minor surgical procedures, the kind of procedures we do in primary care or urgent care regularly. And as I always say, you may not be doing any of them. You may not be doing all of them. Some of you are doing some of them. So I've selected those. But if we can circle back to the first session, the CPT code or the HCPCS code says what you've done. So CPT is those 5 numbers developed by the American Medical Association. HCPCS, a letter and 4 numbers developed by Medicare. And they tell the payer what you've done when you close the encounter and you end the visit, you say what you've done. And the diagnosis code establishes the medical necessity. It's why you've done it. And it also, if we go back to Dr. Fabricant, it also tells the insurance company just how sick this patient is, how sick this patient is at this encounter, and how sick your whole population of patients is as well. So looks like I have a chat. So Lynn is saying that you have one complete template for all 3 wellness visits. That's great. It's really helpful to have one template that has the requirements of all of them. And then the MA is supposed to choose the correct template for these visits. That's the challenge, isn't it? Is making sure that the appointment type is scheduled. It's scheduled as the right appointment type, and that the medical assistant chooses the right template. If both of those things happen, it makes us much happier. It makes it easier. All right. Does anyone else have any questions that they want to put in chat, or would they like to unmute and make a comment or ask a question? And Lynn, thanks for joining in today. I appreciate that, and for your input. It really helps a lot to know what's really happening on the ground. So thank you. All right, it doesn't look like I'm going to get any questions today. But thank you for joining me, and I look forward to seeing you next week.